I'm a senior lecturer in the Department of Psychological Medicine and the Associate Dean of Student Affairs here at University of Otago, Wellington. And I've been asked to chair this session and introduce a friend and a colleague of mine who's come all the way from Canada and will be going across to Australia for some of her work in a few days' time. Angela Bowen is out with her husband Rudy, who presented yesterday, but Angela's presenting today. Angela is a registered nurse and a trained midwife, and she's the professor within the College of Nursing and the Department of Psychiatry at the University of Saskatchewan. Angela has extensive experience as a clinical educator, administrator, and experiences in obstetrics and mental health. Her research focus in maternal mental health brings these areas of expertise together. Angela's actually got quite a long resume here, which I'm not going to go through. She's done a lot of work in Canada, and she will be telling us a little bit about this today. And she has done some important work reviewing of the maternal mental health in Indigenous women in Australia and New Zealand and United States and Canada. So has a broad international experience. So without saying too much more, I'm going to hand over to Angela, and then we'll take some questions at the end as well.
Thank you.
And thank you very much and welcome.
Thank you. I moved to Canada when I was 8 years old, and when you come from the United Kingdom, you're our cousin, as is Australia. That's how I've always felt about it. And my mother wanted to be far away from my grandmother, and my father didn't want to be far away from his mother. So that meant that we moved to Canada instead of Australia or New Zealand. So I've been to Australia many times now, and to come to New Zealand it's completed that vision for me of what might have been. And it's a lot of steep things here. Even your lecture theaters are very steep. So anyway, but it's a beautiful, beautiful country. You have every reason to be proud. So, I guess I have to use this one. I'm pressing enter. Oh, there we go. So Canada's huge. And I think we're smaller than Russia, but we're huge. I've lived from Vancouver Island over to Prince Edward Island, which is over by the Pink, Newfoundland. Right now I live in Saskatoon. I've lived there 3 times. I keep moving back, where that red star is. And I've traveled throughout the province, worked up in Lake Athabasca, planning Aboriginal health services up there, down to the lower border. And most people know about Calgary, which is near Banff, but majority of people just fly right over us. So you're happy to come to my home. You're welcome, because nobody ever does. So I'm very comfortable saying that. This is our cottage, although it's a very flat. We also have many, many lakes. Those are pelicans. I encountered some pelicans in Perth last year and wondered if they might be the same. We lose them in October, and it's a big deal, the first sighting of the first pelican in May. This is canola. This is also near our cottage on the drive home. And it's bright, bright yellow. That doesn't represent the contrast with the sky well enough. It's gorgeous. Canola is also called rapeseed oil. And it's just spectacular to see. And yes, most little guys in Canada do play hockey. That's our oldest grandson. And he just loves his little outfit. I mean, it's just amazing. And he actually has a mild palsy, so he doesn't walk very well. He actually trips a lot, but the kid can skate. Like, he just gets out there and he loves it. He loves it. And that's his younger brother, who is just going to start skating, just realizing that maybe his brother does things that are kind of cool. But that's just snowshoeing in our driveway, actually. So whenever I talk about maternal mental health of any kind, I always just say that to be aware that anything I could say could trigger. I'm not going to go into all the ins and outs that I might in different lectures, but I'm still going to talk about things that we're doing. And for some people, this can trigger, nothing happened for me, or that I'm still sad. So just for you to be aware of it. This slide hasn't changed much. I've started started my PhD actually in 2003 and started giving talks shortly after and about this topic. And 2020 seemed awfully long away. And now I've got things booked into 2019. And World Health Organization that depression would be the greatest cause of disease, burden, premature death, and disability. But it already is in women. Women of childbearing age 15 to 44 being the most at risk. It is the #1 obstetrical complication. And that particular phrase seems to be what's affecting our obstetricians where I am. That's an eye-opener. And we don't hesitate. I work in a tertiary care center. We do not hesitate to spend anything to stop one blood clot or one hemorrhage. There's never a question, can I screen for gestational diabetes? Oh, because I won't know what to do afterwards. So there's a lot of work to continue to educate about what needs to be done. It is the #1 cause of maternal death, that is pregnancy and the first year of postpartum. It's an important problem, but it's not one that's properly being addressed yet. Perinatal mood and anxiety disorders, what the American Psychiatric Association, DSM, decided we would call it. I don't hear anybody call it that. People still talk about postpartum depression mostly. There's a real annoying habit in North America of saying a woman's postpartum, like she's loco or some other thing. Postpartum is a state in terms of time in your life, not a condition that you have. So I continually correct that. I just find it particularly annoying. Moms seem to like to talk that way, but it is a time period. We talk about anxiety, and I think anxiety is completely underestimated in terms of its relationship with depression. There's a temporal relationship. Anxious teenagers who are not treated more likely to be depressed. Lots of research, including ours, that show that women who are anxious in pregnancy are much more likely to get depressed later if not treated or identified. And we use the Edinburgh Postnatal Depression Scale, which has 3 items that are a pretty good proxy for anxiety, items 3, 4, and 5. And in the pregnant moms, a lot of their score, if it's high, comes from those 3 items, the anxiety symptoms, compared to in the postpartum period, more the pure depression symptoms that they address in the EPDS 1, 2, and 8, or the whole score, the whole tool as a whole. Sorry. So anxiety, a lot of moms will admit to being anxious. What's normal anxiety? What's abnormal anxiety? We often praise women because they ask us questions. They're interested. They're keen. They want to keep the babies clean. Lots of things that we normalize as anxious, good mom behavior can be really very troubling and crippling to a lot of women. There's a lot of interest where I am now in post-traumatic stress disorder. Women who come into childbearing having that problem, having been abused or having been traumatized in some way, but also, and as an old obstetrical nurse, for me, the traumas that we cause, that we create on an ongoing basis. So I was really glad when our neonatal intensive care asked me to speak at their education days. So that was 5 times at 7:30 in the morning. I'm not a morning person. But I did it because I'm so keen for them to realize the trauma of just having a baby in there and the things that are done and lights, camera, action. We have cameras now in our NICU, so the moms can watch their babies all the time. Can you imagine for someone with OCD or anxiety? You get up to pee in the night, most people look at the time or look at their phone. Well, they can look at their babies and who's doing what with them. So they're finding it, good in terms of knowledge, that they're knowing what's happening, but nobody's measuring, are these women now sleeping at all? What is the anxiety level? The nurses aren't so keen because they're being watched all the time by the moms. But anyway, in terms of anxiety and this trauma, trying to look at things we can do to ameliorate that. Bipolar disorder, very important. Anybody with a history of bipolar disorder that goes into pregnancy, much more likely to have psychosis. We only have 1 or 2 a year in our immediate catchment area, and that's fine because we have about 5,000 births, and it's 1 to 2 per 1,000. So, and not all the births are from where we are. So we think that we're doing a pretty good job now staying on top of it. PINCs are a concept that are new. Most births in Canada are by GPs and obstetricians. We have very few midwives, particularly where I am. So most births are in hospital, and many women get discharged 12, 13 hours postpartum in this high phase. So they are really happy. We're glad, they're euphoric. But for the woman with a history of bipolar disorder, no sleep, having, maybe been induced, 2 or 3 days of chaos, visitors, all of this stuff, what goes up really high, we know comes down. So trying to make sure women get home visits and those things, that they are increased vulnerability to have problems later. So why do we care? This poster's from 1919, so it's 100 years old. No shock can mark an unborn baby, no horrible sight can deform him, but worry, fear, and anger may affect his mother's blood. And anxiety, depression, all of those things, a lot of the chemicals are the very same that pass through the placenta, cortisol being one of them, that we know has an effect on developing children. May affect his mother's blood, which supplies his food. Therefore, she should be calm, happy, and sweet-tempered. And people always smile at that one because no pressure there, ladies, right? And I mean, these are just a bunch of old biddies. And I always like to say the one with their hand on her hip, like it's remarkably like my grandma in Wales. But now our moms, I don't know about yours, but we have women actually in the hospital who want to work all day and then come up and start being induced. Like they give themselves no time for the pregnancy, everything. They save their maternity, their vacation, everything they can until afterwards, but not giving themselves or their bodies time to recognize the pregnancy. It's a lot about buying stuff and preparing in that way, but putting their feet up and just relaxing, not a whole lot from what I see. And this is from one of our Indigenous elders, that the same concept, that what a mother feels and hears, the child feels and hears. So to always be aware of that. So one of my goals is, a little TLC, a little calmness to bring that. Well, that shouldn't be up there all the time, but for some reason it is. Just to say that, there are medical and obstetrical complications for the mom. Fetal and newborn health can be affected. Breastfeeding, complicated relationship. We know that moms who are breastfeeding, they get lots of oxytocin, prolactin. I mean, in the States, you can buy those in capsule form because they make you feel good, right? Moms who breastfeed for 6, 7 years, my husband's a psychiatrist, he's convinced that's because they like those rushes that they get. Development of the child. And I always like to say to people, the moms, I mean, I'm old now and getting forgetful, but women who have been depressed their whole lives and not been treated are much more likely to have cognitive impairments. So although it's just the obstetrical time that I talk about, there are long-term implications to the health of the whole family. And this is our opportunity to start picking them up. So we did a longitudinal study from pregnancy to 5 years. And we still have graduate students who are analyzing that data. We started with 649 women. Why we didn't wait for 650, I have absolutely no idea. But we were looking for 645, and the research assistants just kept going a tiny bit. And we confirmed that, yes, about 20% of women will suffer from one of these in pregnancy or postpartum, and lots of things that were really quite good from it. But at the same time, because I am this old nurse, it wasn't enough for me. I finished my PhD when I was 52, so I was late coming to all of this. And I thought, if we're going to be doing this research where we were screening people, well, then I started a program with a psychiatrist and psychologist and a nurse, and got some funding for that, research funding that they were able to continue with. But I also felt we needed to do more. And particularly in our province that is geographically challenged, is the best way to put it. There's only 1 million people. You saw that it takes up some part of Canada, of the 35 million that we have, and it's really spread out from the very top to the very bottom and across. So certainly our Indigenous communities, you get 85 people in some of them, a few hundred. So healthcare services are really challenged by that. But I wanted to increase awareness because I knew that people were not being captured, they were not being screened, nothing was being done. So I felt we needed to do something. We got some knowledge translation money from the same people who funded us to do the big study, which was really good, and from one of our major banks to try and build capacity and do some policy work to make some change. And we called it motherfirst because there was a patient first project going on at the time, and that seemed like a good idea. I was fortunate to have a graduate student from our School of Public Policy and really worked hard, and that was her thesis, so it was really good. But I was really lucky that these women, the Smiling Mask women, had produced this book. And they live in Regina, so that's 3 hours south from where I am. And two of the ladies, the top two, psychotic, very, very ill. The one in the red dress took herself into CTV, which is one of our big national television, somehow got herself in onto the news. I'm sure they changed security somewhat since then, but to talk about God. And she was very, very ill and preeclamptic and just had everything go on. The other lady at the top, her marriage did not survive. All of them never had another child. The lady at the bottom continues to work with me, and I made her my co-chair in the work that we do because she's a mom with lived experience. And I didn't. I had the blues, but that was as much as it got for me. So it's not that I can speak from the heart on how this felt, but the moms can. And so I support them with the data and the other things, and we work together. So one year I gave, I can't remember if it was 103 or 105 talks, and many of those I took at least one of them with me. And they produced a DVD from their book, and it worked really well. So we developed this mother-first strategy, and I still get requests from it. It seems impossible it was that long ago. We did have a grand presentation to the Minister of Health, who came from Regina, that's the head of our province. And the press were there, everybody. It was really, really good. And I thought, well, I'm handing it over now. I have other work to do. Just get on with what I need to do. And he handed it back and said, well, now go implement it. So that's what we did. And our committee that developed it continues to work together. So we've been very active. That's me giving it to Justin Trudeau, because everybody seems to like him, whatever country I go to. And he is drop dead gorgeous in real life. I got to tell you, those eyes are just to melt for. But I doubt he read it, but I did give it to him. So our first recommendation was education to increase awareness of not just postpartum depression, but the anxiety and the antenatal. Because although I was, trained midwife, educator in obstetrics, director of our mental health services tertiary care unit, all kinds of things, it was a revelation to me that women got depressed in pregnancy. It was a surprise. I thought I had a light bulb moment when I realized this could happen. And I thought I had really discovered plutonium again. Go online, and sure enough, it was in the 1840s that it was first described, melancholia in pregnancy. So I knew others also. If I didn't know, then others needed to know too. So I worked with, it's like a clearinghouse, our Prevention Institute, to develop posters and for them to distribute them, because my house is only so big, only so much I can do. We had a website. Our psychology PhD program, they could go through and graduate and never hear about this. So they now at least have a class. The social workers, certainly I still teach clinically and I teach theory obstetrics in our nursing program. So they all certainly get it. The medical students now all go through our program that we develop. So it's really quite good. Many of the physicians in Saskatchewan have TV cameras where there's little health messages. And I was sitting there one day and it was you and your prostate, enough of that. So then we got maternal mental health up there. And so we bring it back regularly. It was actually on for almost 3 years and then we bring it back. So it's just 3 or 4 slides with important information and that they can contact our health line, which is 811. So that's 24/7 that it's available. And I'll talk more about the work that they've been able to do. We have also a provincial medication line. And I'm also part of the breastfeeding coalition as I don't know how keen you are with baby friendly initiative, but we're really got some very keen people and I'm part of that. So one of the things is always to reassure pregnant, postpartum, lactating moms of any medication that they want to take. So my husband, who's worked in our city for 40 years, did not know about this service. And it's for professionals and lay people. So when my daughter asked me how much ibuprofen she could take after a C-section, I knew, but I said, well, let's try this number and see what happens. And sure enough, they were very helpful, gave me her exactly what I knew she needed to know, and it was really good. And I made friends with the media, moms who were journalists. So I have no problem contacting them and saying, on their CBC morning talk show, whatever, call-in shows, we've done it all. So it really works well. These are the posters that we produced, and they're a good size. There were 2 mail-outs to everybody who does prenatal, postnatal, intrapartum care in the province, 2 different times. The reason we started with that, are you enjoying pregnancy or being the mother of a new baby, was, first of all, it's the second diagnostic criteria, anhedonia, for depression. But the lady in the red dress who, went into the TV station, who was extremely ill, baby was born 27 weeks, all kinds of things. For her, if someone had just said to her, how are you enjoying being pregnant? She would have just said, I'm not. There was nothing in her, no joy whatsoever, nothing, blackness, from being a very active person. So we do have tear-off sheets that also have the EPDS on the back with information on the front, these little cardstock things that fit into those brochure sleeves. Those are also quite popular. Our second recommendation was universal screening. In 2009, we had a conference and with the Smiling Mass Women, and at that time we met for half of that conference, the last day, and with the moms, because there were a lot of moms there. What did they want? And they were so clear that they wanted us to normalize. We care as much about your mental, emotional health as we do your physical health. There is no hesitation to go into every orifice this woman owns. And yet to say more than how are you today seems to be a struggle for some people. And to look her in the eye and see if she's looking back at you, it seems to be an issue. So the Edinburgh Postnatal Depression Scale, used worldwide, I like to say I'd like to find the person that finds it doesn't work. It's like up to 43 languages, men, cancer patients. What it does is it takes out the somatic symptoms that are usually associated with depression. That's the main thing it does. And it's free, it's available, it's only 10 questions. The women are women, a lot of them now know it, they're quite familiar with it. So it's twice in pregnancy, at the first visit, and then again 28 to 32, 34 weeks, because we know there's harm to the baby if it isn't diagnosed. So why would we wait till the second or third trimester to do it? And because we know the babies are more likely to be born preterm and have difficulties, we don't want her walking into the highest part of her life in terms of prevalence of psychosis in that postpartum period with illness. We want her to be as healthy and protected as possible. And then in postpartum, our public health nurses really jumped on this. We have the head of the public health nurse group on our committee, of course. and they wanted to own it because I think they didn't trust the doctors to do it postpartum, but that's fine. So they, at their child health checks, they don't call them immunization visits anymore. They will do it, and before they discharge, usually they do a visit in that first 2 or 3 weeks. So before they say you're okay to come at 2 months, they will go in and do a visit and screen then. The moms weren't happy that, particularly Alita, the ladies on my committee, that there wasn't screening in pregnancy. That we have a form that gets renovated once in a while, a prenatal form. And I'd been able to put on history of depression and a few other things early on, and probably in 2004. But they were talking about doing changes to it again. So the group, we started a change.org petition to get it on. We had, when we presented it, we have more now, but when we presented it to the Minister of Health on World Maternal Mental Health Day, had it periscoped in. So the whole world got to see him, and politicians just love that stuff, right? The press was there. How could he say no? He already knew this was going to happen. So he'd already gotten that approval that I would be on the prenatal form revision committee, and that we would get this prenatal screening on there. So we're just finalizing it now. We also put the women abuse screening tool, which is the short 2-question version. And I'll show you that in a second. Hopefully it'll show up. And the taste. And there's the tweak, the taste. I can't remember what Mark said, which one you used, but it's just for picking up alcohol problems. And again, those child health checks. And we have, for our Indigenous or socially vulnerable moms, a lot of outreach programs. And they all also screen. So we've had some women say, well, she just did that. That was just done at the doctor's office, whatever. I mean, other than perhaps being annoying, there's no learned effect from doing the EPDS. You don't get better or worse at it if you do it. There's been one study where they did it every week for 52 weeks. So we just say them, no worries. If you did it, we can get the score or whatever. But people can do it whenever they feel it's warranted. So the top is, this will be a separate sheet, because putting it on the prenatal form, which is what we said we want, is ridiculous, because the doctors have that and many of them have it on a computer. So that doesn't make any sense. So for the women then, what they do now is they get a clipboard and fill it out, and the secretary or whoever will give it to them. So this now has everything on it that we want to be assessed. So it has the EPDS, and we highlight on the EPDS those 3 anxiety items, so people can look at it and say, oh, that's where the problem is. And then the second is this Woman Abuse Screening Tool 2 item questionnaire. There's a 10-point version. And why I like this, and we use this actually in our studies too as a proxy, is that it doesn't force the women to say, and particularly if someone else is there while she's filling in the form, that yes, I'm being abused, but it is a sign, and a good one, that there are problems in the relationship that may indicate abuse. So the first question is, in general, how would you describe your relationship? A lot of tension, some tension, no tension, right? A lot of tension. And we know, I was the chair of our interval house, it's called our abuse transition home, that is that cycle of violence, right? The building of the tension, and then, the event happens. Do you and your partner work out arguments with great difficulty, some difficulty, no difficulty? So if they're having problems, great difficulty, or a lot of tension, then you know that you need to pursue more in terms of information about how they're getting along. And then the taste is just, as I said, an alcohol screening tool. So one of the obstetricians, who's very busy obstetrician, very good obstetrician, on this revision committee said, well, that's good, I'll do it, and I know she's already doing the postpartum because she's my daughter's doctor, but she said, what I need is a poster when I look up from the examining bed to remind me these things, that even though she'll have the form there, she just wants this. So this is just something I've been working on and playing around with, just trying to keep our logo, keep the colors, keep the feel of other things that you will see, when to screen, that kind of thing. I haven't had her feedback yet. I just did it a week or so ago. So what are these things that they're going to be looking at? But we had already produced this care guide, and it has been quite popular. And it comes on a card stock. We have on the back, again, the EPDS and how they use it. So it talks about the scores, anxiety, what kinds of things you can do, some of the medical management, because we still have doctors who discontinue antidepressants and mood stabilizing drugs as soon as she finds out she's pregnant. A study with Adrienne Arneson years ago where they, women went into pharmacists with prescriptions who are pregnant, and the pharmacist saying you don't want to take this drug, not wanting to fill it, like a lot of ignorance about, the balance between untreated and treated depression. So lots of just tips there for them, and it's been adapted and used in other places, which we're happy about. Our third recommendation was to prioritize pregnant and postpartum women in mental health services. And because we don't now, we just got one whole health region, which I think is way better. Like some areas within it, some cities, but instead of 13 parties all having their own budget and deciding what they do with it, was crazy. So in Regina, they would not do it. They just would not do it. It has to be based on symptoms. It cannot be based on a condition, because it was a guy, Joe, that he would not do it. So we're hopeful, working with the Minister of Health now and the new CEO, that we will be able to change that, because we were able to change it in most of the regions. That if a woman was identified as postpartum or pregnant, she would, because you're treating 2 for 1 here, and because there was a family involved in the seriousness of it, because we had some suicides. We had a mom who stabbed her baby in the Fontanelle with a pen, and that baby will cost our province millions of dollars in its lifetime, literally. So they got a new computer system for their intake for mental health, which does include pregnancy. It'll say postpartum. I thought we'll just add a box, but apparently that's not easy to do with IT things when you buy a package. What we are really good at is women with dual disorders. So if she's drugs and or alcohol, within 72 hours, she's an inpatient. Sooner if she can, other kids don't have to be dealt with. So that is good, and they will prioritize our moms. The third recommendation included different treatment options, because in a province so spread out, we don't have enough counselors. We don't have enough psychologists. We only had one perinatal psychiatrist at that time, who's now the department head. So we've been looking for other ways. Doc in the box, it's called remote presence technology, which I don't see why we can't do it on Zoom or some of these other things, but we need all this encryption and security. We tested this with postpartum moms, online CBT. The moms really liked it. It was very positive. We know that just listening to moms, just acknowledging them is helpful. So when we have outreach workers and our Indigenous moms who are at higher risk, then we need to have ways for those peer supporters and outreach workers to help them. And I'll show you to that next. Exercise, what was minus 30 the other day? You aren't going to go out in a stroller too much in that one. If you're in a small community, there's nowhere to walk. And in some of the Indigenous communities, I've been to many of them, the dogs are a real problem. They run around in those communities. You don't want to go for a walk. It's really quite frightening, to tell you the truth. So exercise, we showed a dose response in the inner city women. And at first I was really surprised, like, gee, like how could that be? Until when you work with the program, they were really quick to say to me, well, these women don't have cars. They have to walk to their visits. They have to walk to take the kids to school, all of those things. So these women were walking lots, and it was just a beautiful little graph of the more they walked, the less depressed that they were. Light therapy. My husband isn't here right now, so I freely tell the world that in the winter, it's dark when we go to work. It's dark when we come home. So when he goes up to check in his office in our house to check his computer, he also has a bright light right there. So he has 2 screens going, and he's getting it. Women like that because it's not invasive. So many of our health regions have borrowed those out to women, lent them out, and that works well for many women. Sleep, I always emphasize that so much, just so important. And I'm not the greatest sleeper in the world myself, but really trying to promote that. It doesn't cost anything other than maybe people bringing food so you don't have to cook, or, people supporting the mom. Peer support, group support, that's really actually what got me into this, was evaluating our postpartum support group in town. They asked me to do it when I was a student. And there'd be moms like, it's 1 year now, you got to move on. We have other people who need the program. They just love that support. A lot are getting it now through online, Facebook, those kind of groups, but that also can also be harmful if it's not facilitated. So we have to really watch that. One of the things that was a bit of a revelation for me in one of my visits to Perth was, and we were up in Karratha, it's called, Roburn area, and one of the elders there, and talking about TLC, just caring for other people. If they look sad, to talk to them. And really, any of you who are nurses, we always see ourselves as the TLC experts, right? Tender, loving care. But, doing more, paying forward, being kind to these moms. So after hearing one of my talks, a church group decided that for the first 6 weeks, a mom had a baby in their congregation, that they would provide a certain number of meals per week. Great. TLC at its very best. Practical, helps the mom, helps the family. And then we developed these toolkits, because the other care guide was very clearly for healthcare practitioners. And we do have lots of these outreach workers, and they wanted something more. So we're screening these moms, then what? We don't know what to do. They're visiting them in their homes every week for the entire pregnancy and for the first while postpartum. They wanted to be able to discuss things. So we came up with one-page information sheets that are not designed to be left. They work through them with the moms. They actually have little, I didn't put that slide in, but they have a bag that they take that has, one of them, they have a little fence for boundaries. They have a little box with Tic Tacs. They're little candies for drugs, and a boob for the breastfeeding, and a little baby bed. And they'll say to them, and what do you want to talk about? Or they'll just go in and randomly choose something. Let's talk about this today. We did test them with a group of Indigenous and socially vulnerable moms, and they added a few more to it: loss and grief, boundaries. These girls have a real struggle with their cell phone, and I don't know if you call it here, but in America, baby daddy. It's just very annoying. But they'll be online talking about this and that, and spending so much time. They've got their curtains drawn, and they're inside on their cell phones. They're not getting sunlight. They're not getting out. They're really wrapped up in this, and ignoring their babies. In terms of stimulation, a lot of our Indigenous families experience an awful lot of loss and grief. When I have students in clinical, it's not unusual. I've got a funeral, I got to go back to my community, 8-hour drive, it happens all the time. Medications, as I said, people get really anxious about medications in our population, but if you can't concentrate in a support group, you may need medications to stabilize the mom's mood, and to participate and not to taper. When I first started giving these talks, we still talked about tapering those last few weeks. Well, that's the exact wrong thing to do. And in fact, because of the increase in blood volume in pregnancy, it should be what her symptoms are, and it may mean an increase, not a decrease. So it's a combination of approaches. So as I said, I involved our health line early on, 811. And they took our logo without asking us, which, was a bit offensive, but not entirely, and made 13,000 fridge magnets. Everybody who had a baby that year in Saskatchewan got a fridge magnet with 811 on it, and maternal wellness program. And they developed a program where the public health nurses can call in, and they will call out. It's the only outgoing call they do. So if your child eats some plant and you think it might be poisonous, you phone them. Or, my back hurts, should I go to the hospital? You phone them. They don't phone you back except for this. So the public health nurses can phone and say, I've just visited this mom. She needs some help wherever she is in the province. And they will stay connected until they get her involved in some other kind of counseling or whatever. And if there's physical issues, they'll deal with those. They'll transfer to an RN. These are social workers and psychiatric nurses. So the government was happy to tell us last year that all of the areas in our province are now connected with this. They very slow rollout, but they still did it. The physicians now want to be able to have that same access, so that's what we're working on, and pregnant moms, so that anybody really can refer, and anybody can phone into them and get service, but they won't necessarily phone out to. Our government's very controlling. I don't know about yours. So recommendation number 4 was sustainability. So if I decide I love New Zealand and Australia and I'd want to stay here, if it wasn't for the grandchildren, I probably would, then we need this to continue. And I think by engaging these moms over the years, they are really vested in this, and they want this to happen. So we meet regularly. This year it's been twice with the Minister of Health, and if there's a new Minister of Health, we make sure we're there. And as I said, the One Health region, we're hopeful. So what's happening elsewhere? A few years ago, Jeanette Milgram, who's in Melbourne, asked me to participate in this book with her, International Approaches to Perinatal Mental Health Screening as a Public Health Priority, was the chapter that I helped to write. So what's happening in Canada overall? Canadian Psychiatric Association and the Society of Obstetricians and Gynecologists, the head of those two professions, we're going to put out a joint statement. Well, I've been waiting 2.5, 3 years now for this. I don't know what they're up to. We've written letters to them. They have not told us. One of the mums groups in Ontario is going to meet with them, so I'm glad about that. Health Canada, we have family-centered maternity guidelines that kind of are the Bible that managers and educators will refer to. I was on that committee. We have been able to make sure the screening is in there, preconceptually upward. Registered Nurses Association of Ontario, where most people in Canada live, these best practice guidelines that they have for everything, falls, you name it, within nursing. I was the co-chair of that. And we did the work, and it was over 1.5 years, and they still have not published it. Like, I don't understand. You know, I regularly ask them, when is it coming out? Because the old version was just postpartum depression. We changed it to be perinatal, and still waiting for it. So our goal, and why I gave that to Justin Trudeau, was to get a national strategy. Only us in British Columbia have the kind of thing I'm talking about. And we had a Canada group that we would WebEx and talk all the time, but it was mostly professionals. And I kept saying, don't we know any moms groups outside of us? And now we've connected with those, Life with Baby, Postpartum Progress. And the goal is a national strategy, and that one of them has funding, so let's go for it. You know, I'll let them drive the bus and support them, so that'll be good. We're calling ourselves the Canadian Alliance for Maternal Mental Health, mostly after the UK, because there's a global alliance that's just been formalized, that's come out, just to follow along with that. The United States, the greatest country on earth, living above them, I'm fully aware of this all the time. But you know what? They are really slack when it comes to motherhood. There is no mandatory maternity leave. In Canada, 1 year minimum, 2 years. 1 year, you get 2/3 of your pay. And many employers will top it up to be the whole pay, and nothing. So a lot of people there, if you're a teacher, you plan to have your baby in June, so you at least get the summer off. So their breastfeeding rates are low. I mean, it's really dismal. And they had this Melanie Blocker-Stokes Act, and we had her mother. She was a girl who committed suicide, a new mom. We had her mom come and talk to us about getting legislation and what could happen. So they've had this act for a long time, and it's still not mandatory. There still is no national strategy there. They have some really good researchers who work hard on this, and they just haven't been able to have it happen. They do have joint statements from the American Psychiatric Association and the American College of Obstetricians and Gynecologists. So that was, you know, our goal as we were pushing for this joint statement to come in Canada as well. They have published and they've updated that. But I really do feel that this is still very much a forgotten group of people. Obstetricians basically scared of it, although we have some obstetricians now that we've worked with who are prescribing when they see moms, because we have a consultation liaison model. They've had so much experience now getting letters back how to manage care that they're comfortable doing it, and they're initiating some care. I truly believe if you have a medical problem in the United States, you know, the Mayo Clinic, all those things, people come from all over the world to get surgery. If you've got money, it's the best care in the world, but they really are lagging behind whatever is happening. And I didn't write the chapter in the book on this part. That was Catherine Wisner, who's really quite famous and very involved in trying to make this happen. There's always a story online about a mom taking her life from the United States. This is from your America, Australia. And from what I understand now, the beyondblue has turned over their perinatal portion to COPE, Center for Perinatal Excellence, with Nicole. I'm not sure always how to say Hyatt, how to say her name, how to pronounce it. But she's also part of this World Maternal Mental Health group that we have, and she's a lovely lady as well. So they, I believe, have done a lot in terms of screening, the universal screening, and how they approach it, the materials that they have. But when I was, I think it was about 3 years ago, when I was in a place called Geraldton on the west coast of Australia, they had this lovely counselor. It's a small area, you know, maybe 10,000 people at the very most, I don't know, but they had a worker who was doing the perinatal counseling, and the government had just cut it. So, you know, when you do that, and they were like, what are we going to do? Like, they just didn't know what they were going to do. So you got to put your money where your mouth is when it comes to this stuff and supporting the moms. I think the UK has been the flagship for a lot of this, starting, you know, even with supporting that person years ago killed her husband who had PMS, like understanding moods and outcomes and all of those things. I think that they have the NICE guidelines. They have also the SIGN guidelines, which actually, I don't know if they just hate the EPDS or what, but they don't support routine universal screening in there. So that was a bit of a concern for us as we were moving forward. But you know what? It's better than nothing from if we evolve that we don't need it anymore because everybody's doing it, well, then fine. But we're sticking with it. Another chapter in the book was, another portion of our chapter was France. And they're expected to do this assessment, but when they did an audit, only 21% of couples, because it's to be a couple's psychological assessment, only 20% or so had been done. So see, left to their own devices, people don't necessarily do it. It's easy to forget. It's the one you do last after everything else. And they do have a large epidemiological study, and they'll complete that. So New Zealand, you have on May 2nd, you're having a conference right here. So if you don't know about it, ask Mark, he's hosting it, and he'll tell you. I'll talk very quickly because they're telling me my time's up. So, but I gotta finish a little bit. So certificate of recognition, I wanted to increase awareness and continue buy-in from the government. So I got them to proclaim Maternal Mental Health Day, got us good press. I put it onto all the listservs that I belong to, PSI Marseille. And before you know it, we had a world one. And that's our logo. May 4th was our first one. May 2nd will be the next one, as I said, mostly online. This is just, I'll have in the TVs in our hospital in PEDS and OBS. 2020, that's our goal as a world group, because remember what I said, by 2020, it'll be the greatest cause of disease and disability. So there's a moms group in the States, Moms 2020. That's our goal, is to get the World Health Organization to acknowledge by then. That's our conference that's coming up. And my work now is just getting into, I think a lot of it begins with birth and kinship, so that's where I'm going with that. And I'll just take questions now. I won't go to the other slides.
Thank you very much. That's very, very interesting. I'm Amanda Coswick. I'm here in the Department of Public Health and Child Health Research. So while you were speaking, I was thinking forward in time to what happens with the mother and her baby and to that infant's mental health. And have you looked at or thought about, or I would like to be interested to know what your thoughts are about, can you hear me? Can you hear me now? Oh, sorry everybody. Your thoughts about screening maternal responsiveness and infant mental health. So not just mums, but also the interaction between mums and their babies.
Yeah, absolutely, the interaction. And when I first heard about one of our psychiatrists, sadly died, but she opened an infant mental health clinic when I was the director of psychiatry. And I thought, oh my God, this is crazy. Like, what are you going to see? But I've seen videos of offspring, 6-week-old babies of mothers who were depressed in pregnancy and continue to be depressed and not. These are from Cambridge. I took a course in perinatal depression at Reading University, and they produced these videos in Cambridge. And to see those babies and the difference in them, even just the interaction, the baby's ability to follow anybody who would not believe there was a difference. Really, there absolutely is those breastfeeding problems. And, what I always say is, okay, maybe she was depressed in pregnancy and I had PMS. So suddenly you start your period, the lights go on and the world's normal. So for some moms who were depressed in pregnancy and now they feel good, but they've got this little baby, and I certainly encountered it, who isn't cuddly and snuggly, who doesn't respond, and then she feels rejected, and then the postpartum depression can start. But the babies, just as the elder in those old bags 100 years ago thought, the babies have been affected by, bathed in cortisol for months, and that interaction, and they've shown in primates that children, little monkeys, that they stress the moms, they do things to them, that stress reaction is there, and the cortisol response is there, a pattern of response. And these babies are born with it. So that interaction is affected. And if she's continuing to struggle, and if she's more likely, we've shown more likely to have bleeds and C-sections and instrumental deliveries, all of those things interacts with how well you can mother right away. I had a section, hurt like hell. I mean, you need to be able to move around. And yet we expect moms to go home 24 to 48 hours. Can you imagine? After that kind of surgery. And then they're supposed to just be all loving and sweet and wonderful. It's very difficult. So measuring the outcomes in the children, because a lot of our moms, unfortunately, in the 649 that we had were upper income moms. I had 402 socially vulnerable moms. Most of the children fared well because there was other people stimulating, reading to the children. They were involved in programs, they got into play dates and all those things very early. But those moms, those smiling mask women, their children struggle and continue to with anxiety. They've gotten them into care. One of them's doing mindfulness. She's 9 and is very cool, but they've struggled. Yeah, you cannot ignore that. And, to me, it's just someone else's work because I'm so involved in what I do. But yeah, that's what we want to prevent, those problems. Yeah.
Thank you very much. That was very interesting, and congratulations to the men in the room. My name's Philippa and I'm in public health too. I used to work in an alcohol and drug unit, and we followed a Canadian policy called pregnant pause, which was when the woman was pregnant, the whole household would take stock of the nest and what needs to be done in terms of lowering alcohol consumption and so forth. And so I was just interested in your focus here on the mothers rather than the family or the whānau here, because we know from breastfeeding, if the partner doesn't agree, the one is less likely to do so. So can you talk me through a bit why the focus solely on the mother rather than the family, particularly given the Indigenous focus of a lot of your work?
Certainly the Indigenous families struggle the most with the moms trying to abstain. So if you see under where they have a score of 12 or more, we have that little square. It says offer EPDS to partner, because we recognize that the partners too, there's It was Goodman, I believe, published, and that was like 11 o'clock news, which is the big news where I live. At night, the big news was that fathers have 10% postpartum depression if the mothers are depressed. And it can be, the more anxious or depressed she is, the more it can impact the dads. We know dads get the blues. We know they get depressed, but they usually come a little bit later. So we don't totally ignore it. But, you know, we had this discussion when we started talking about the Canadian Alliance. Should it be perinatal mental health and including the dads somehow? But we felt that there's so much work to be done with the moms that we had to start there. So we don't not regard them at all. And certainly anybody in counseling is, where it's a couple, both people need to, you know, be part of that. But we did try a support group for dads in Saskatoon, and that just didn't go anywhere at all. I'm not sure why. We have this in our conference, this PSI certification that we're bringing. It does talk about dads. We were able to get a dad who's also a social worker to present that part. So I don't dismiss it, partners, because it's not all dads, of course, but it's just not been the focus of what I do in terms of my work. And yeah.
Hi, thanks for a great presentation. For pregnant women, there's a lot of instructions they have to take on, and there's a lot to worry about. There's a lot of responsibility.
We feed right into all this. Yeah,
that's right. And so I imagine for someone who's anxious already and then is told that their anxiety might be affecting this little fetus.
Yes, feel terrible.
Provokes extra anxiety.
Mm-hmm.
So I wonder, how do you talk about that connection without kind of ramping up that anxiety further?
Mm-hmm. Well, and by saying some anxiety is normal, some anxiety is good. We don't want you to be slack. But at the same time, you know, it reaches a point where these symptoms can be harmful. So one of the first qualitative studies out of our big study was a psychology student who was looking at, in these mildly depressed moms, because we didn't want to burden the moms who'd scored high for depression, what were their worries about? What were their anxieties about? And one of them was getting in a car and putting on a car seat, like putting on the seatbelt. I'd never, ever thought of that. But that was a major worry for quite a few of them. And whoa, like it, you know, what is your worry about that? Well, the airbag is going to come off. Well, that's a very real worry. You know, that makes sense that you might worry about that because it can happen. But so, you know, I'm not a counselor as such. I have a lot of interaction with the moms in various ways. But if she's got a lot of anxiety, then we try to get her into care. I did try, I got some funding to run a mindfulness group and an interpersonal therapy group. It was so hard to get those moms to come to complete those trials. We went from a 10-week to an 8-week to a 6-week, and then even trying to keep them in there because they're all working, you know, they've got kids. We paid for childcare. I paid for transportation. I did everything. I moved locations. I made it as easy as I could. I had them in the day. I had them in the night. I did everything I could think of. It was so difficult because these moms are just so busy, these pregnant ladies, whereas after they can participate in the postpartum support group because they're not working, right? And because we provide childcare there too. So yeah, it's difficult. We don't want guilt, you know, if something is wrong, but we can't not point it out that your worry is going to be harmful to your baby. So let's find some ways to relax through breathing or whatever. Exercise, excellent. You know, get them into some yoga. We had a yoga program. The moms loved it. Loved it. It's 1:29. We started at 12:30. Not too bad.
So I'd just like to thank you very much, Angela, for taking some of your vacation time and coming and talking to us, and very interesting initiatives in Canada, and you've put a lot of hard work in there, and I know it comes from the heart.
Yes, absolutely.
So
yeah.
just
Thank you.
I'm sure Angela will be around here for a few minutes before she has to
Sure.
finish off with video.
Yes, absolutely. Yeah. And don't forget, May 2nd, here. There's some posters outside, I think. And there's some pens and various University of Saskatchewan things over there. Thank you.